Says back to the class. After the celiac term, we reach to the superior mesenteric. Superior mesenteric separate from the aorta at the level of L1. Then comes down like this course. It's come down like this, and then it's going to supply all the small intestine and the large intestine till this part. Yes, I mentioned this before.
Yeah.
So when it's come down, I mean the superior mesenteric, this is the superior mesenteric coming down here, and at the distance around 50 centimeters remain to ileum being finished here, it's ended to the ileum, to this part of ileum, jejunum ileum, small intestine, yes? Separate a lot of branches from the left side of the superior mesenteric, like this, and supply all the jejunum and ileum except this part. This part I told is 50 centimeters. Remain to being finished, okay? Till this part is finished. Superior mesenteric. Superior mesenteric. From that part, come down, and there are a lot of branches of this that goes to the left and supply jejunum and ileum. Now, there are some branches that separate from this artery and goes to the right, like this, and then reach to the greater, the great intestine, supply this part, and this one, again, anastomus with the end part of the superior mesenteric. This branch, one, is ileoculic. Ileoculic separated from the superior mesenteric at the right side. All the branches of the left side supply the small intestine. So, another branch that separates from these and goes to the right, reach to the right culic flexion. We say right culic flexion and that left culic flexion. When reach here, again it divides to inferior and superior branch. Supply all parts of the right flexure and the ascending column, the part of the ascending column above of this part. It's separate from the ileoculic and then join to each other. This one, number 2, is right culic. So, number 1 was ileoculic because supply ileum and colon, and we expected some branches of this reach to the second and to appendix and supply appendix. Yes? The last branch of this going up and reach to the transverse column, divide into right and left branch and supply all the right two-thirds of the transverse column. This one made culica media. Culica media or middle culic. Maybe you hear name of this middle culic. Yes? So middle culic from the superior mesenteric reach to the transverse column, supply all the right two-thirds of this. Finally, as you can see here, all these branches anastomose to each other, and ileoculic finally anastomose by its source, I mean the superior mesentery. Just remain one small artery. Who can tell me which artery we should be expected to have here?
Left.
Left what?
Left ileoculic.
Left colic? Left colic? No, left colic is the left. Here you are right. Which branches still remain? Please review the figure that I removed, I mean clean here.
Inferior pancreatic.
Inferior?
Pancreatic.
Excellent. Inferior, what was the name of the superior one?
Inferior pancreatic duodenal artery.
Superior pancreatic. So, inferior pancreatic duodenal, inferior
Pancreatic
duodenal should be a branch of superior mesentery. It may be, again, there are a lot of variation for this. It may be separate from the main trunk or from the most first branches that supply the jejunum. So we cannot say exactly separate from the main trunk or not, but we have this here. We just mark here. So as you can see here, superior mesentery supply jejunum and ileum, sacrum, appendix, ascending colon, and right 2/3 of the transverse colon. And of course, the parts of the duodenum that being under the middle of the second part. Duodenum, again, you see this is the duodenum. And from this part, down to the end, supplied by superior mesenteric, and the upper part of the duodenum supplied by celiac trunk. The junction between celiac and superior mesentery should be at this level. Here is the point that the common bile duct from the gallbladder, common bile duct, reach and end to this part. So this part is a part that at the fetal life, the liver bud originates from this part. Liver bud at this point originated. So because of this, we divided foregut, midgut by this attachment of common bile duct. It's clear? So it's about the superior mesentery. Please review, then I will show you the inferior mesentery. Now, please, where is the origin of the inferior mesentery? In which level? In which
L1.
L3. Exactly, don't forget, exactly, at this point, we have the third part of the duodenum. What?
Third
Part of the duodenum. Duodenum, this part, third part, exactly located here. I mean, inferior mesentery is posterior than the third part of the duodenum. So, this artery, I mean inferior mesentery, from this part goes down and to the left. Superior mesentery comes down and to the right. It's come down and to the left. So when it comes down and to the left, we have here we have here the inferior mesenteric artery. Inferior mesenteric. So here we have the descending colon, then what? Sigmoid, and then rectum. That cross the diaphragm and change to anal colon. So look to the inferior mesenteric. When it's come down and to the left, the first branch that's separate from these goes up and to the left, divide into two branches. Some of them descend, another one goes up, and finally anastomus with the left branch of what? Colica media. Finally, look here, the left colic goes to the left and at the descending colon divide into two branches. One of them comes down, another one goes up, and finally anastomose by the left branch of colica media. And then as the inferior mesenteric comes down, when it crosses the pelvic brim. Who knows the pelvic brim? Pelvic brim means this part, sacroiliac joint. The sacroiliac joint that connected to the fifth border of the hip. Can you remember the medial border of the hip? Pelvic. It's terminated here. So the line that made the I'm sure that I told you about the entrance of the pelvic. Can you remember the entrance of the pelvic? Between two medial border of the pelvic, each half of the pelvic has medial border right, medial border. Between these two, we say pelvic entrance. Yes. So when this artery crossed that line, the name changed to what?
Superior rectum.
Excellent. We say superior rectal. Before that, it was what? Inferior mesenteric. So inferior mesenteric, when reached to the pelvic surface after crossing the pelvic inlet, it changed to the superior rectal. When we say superior rectal, it means we expected we have middle rectal and inferior rectal. Middle rectal is a branch of what? Middle rectal. Middle rectal. What is this? Internal iliac. It's a branch of the internal iliac. And inferior rectal is a branch of the main branch of internal iliac. Internal iliac has another branch that we say internal pudendal. What? Internal pudendal. Internal pudendal is a branch of the internal iliac. Same as middle rectal. Middle rectal is a branch of internal iliac. The same internal pudendal is a branch of this artery. But internal pudendal is going to supply genital system. Okay? We will discuss about it in reproductive system. So, internal pudendal on the way has a branch that the name of this branch is excellent. inferior rectal. Am I right?
Yes.
So, the internal iliac, from the internal iliac separate two branches that is related to our discussion. One of them is middle rectal, another one is internal pudendal. Internal pudendal has a branch that is inferior rectal, and superior rectal was the end part of the inferior mesentery. Inferior. When cross what? Pelvic ring. When cross the sacroiliac joint. When crossing this part, the name is, in practical class, if I show you this and you say or you write it's inferior mesenteric, it means you made mistake. Be careful. Okay. Another branch here maybe has a main trunk like this and supply all parts of the sigmoid or separate each of them separately from the inferior mesentery. But it's common that they have a main root, okay, or common root. This is a main root or common root. So it's usual that we say sigmoidal arteries or sigmoidal branch. So again, from this sigmoidal branch, the branch reach to supply this part of the descending column and anastomose by the left colic. So left colic superiorly anastomose by the left branch of the colica media and inferiorly anastomosing by sigmoidal branch, the most upper part of the sigmoidal branch. And here, finally, there is, before it becomes superior rectal, it has a branch that join to each and supply this part of the sigmoid, the most lower part of the sigmoid. If you want to name this, what name do you choose for this branch, the last branch? What? Rectosigmoid. Rectosigmoid. So this one should be rectosigmoid. Rectosigmoid is the last branch of the inferior mesenteric that join to the sigmoidal branch, last sigmoidal branch. And by this, all parts, as you can see here, all parts of the small intestine and greater intestine being supplied by these arteries, and all of them corresponding to each other and make a marginal anastomose or marginal arch. And the point is here. A volunteer answered my question. Please, first of all, review this and then I will ask you a question. Who knows about this rheolon arch? In which part of these anastomose do name the rheolon arch or rheolon anastomose? The junction between the left branch of the colica media, the anastomose is between the left branch of the colica media, left branch, and the right branch of the right colic. Here, this junction make an arc that the name of this arc is Riolan arc. Riolan arc. Riolan arc is important. Of course, we will see on the slide, and then I will explain to you. Riolan arc, okay?
It
Is an anastomus between the culica media and left culic. Culica media and left culic. Here is left or right?
Left branch of colica media and the right branch of
Left culic. This one is right branch of left culic, and this one is left branch of culica media. I want to start a new session about the oral cavity. It can be important. I try to just mention the important parts of the oral cavity. As you can see here, the oral cavity is a cavity that it has a roof, floor, anterior orifice, and posterior orifice. Yes, you can see here. I mean, the oral cavity, this part is one of the important part of the digestive system because we have teeth here and some taste spot that they action are very important in our body. So this one is the anterior entrance of the oral cavity, and this part is the most posterior part or orifice of the oral cavity. This one, anterior one, open to the outside, to our face, and this one open to the larynx and pharynx. I mean the duct that we have behind of our oral cavity. Oral cavity superiorly joined to the nasopharynx, and at this middle joined to the oropharynx, and inferiorly to the laryngopharynx. So we can see the junction between all these parts in a sagittal section. But here you are looking to the oral cavity from the anterior face, and you can see this uvula, a small tongue that we had at the posterior part. So here we expected to have a soft plate. These are soft plate, and here we have hard plate. It made, I mean the oral cavity made by some bony structure and mucosa. That mucosa cover all part of this. Who can tell me about the bones that we have here? How many bones take part to make the oral cavity? There are some paired bones, 3 paired bones, and 3 single bones. You want to tell?
Hyoid bone, hard platelet, soft platelet. No, not soft platelet. Just hard platelet.
Mandible, maxilla. As I told you, there are some paired bones. Paired bones, when we say, I mean this maxilla, it has left and right side, and the maxilla has a part, a bony part, that being vertical
Process.
and process, palatine process that complete the roof of our mouth. And then another bone that related to the oral cavity should be palatine bones. Palatine bones on right and left side being like this, L, okay? And this is the vertical part, and this part is horizontal. This horizontal part of the palatine bone complete the most posterior part of the hard palate. Hard palate. And still one more paired bones that take part to making our oral cavity. Which one you think? Mandible is the just I mean single bone. 3 paired bone, maxilla, palatine, and temporal. So temporal bone, a process of temporal bone take part to complete our oral cavity. And bones that are single, we say mandible, as you mentioned, sphenoid and hyoid. Excellent. Hyoid, sphenoid. I will show you in another picture. So, again, in oral cavity, as you can see here, at the most posterior part, there are some tonsil. These are pharyngeal tonsil. And again, tongue at the most posterior part has some tonsil, lingual tonsil. And one more tonsil that we have at this part, who can tell me about that? Which tonsil do we have extra than the pharyngeal that I show you?
This goes on the tongue.
And tongue, except these two, we have one more tonsil. Where is the location of the third one of tonsil that we have?
The posterior end of the tongue.
Yes, we say this was lingual tonsil, pharyngeal tonsil, and adenoid. Have you heard about this before? Adenoid. Adenoid is the most posterior part at the nasal space. I mean nasopharynx. At the top of the nasopharynx, we have this kind of tonsil, adenoid. Some knows this third tonsil. Third tonsil. It's common in the children and all the time because it's being, hypertrophy. Then surgeon may be remove that. Okay. So oral cavity has a roof and floor. Roof, as I mentioned, made by hard palate and soft palate. Now here you are looking to the soft palate by the uvula and some muscle that we have here. And hard palate made by bony part. Hard palate made by bony part. But the floor of this oral cavity made by muscles, myelohyoid, geniohyoid. Did you pass the cervical, head and neck? Head and no? Ah, okay. Okay, they will discuss about this in future. So, the floor of the oral cavity made by a muscle like this, the same as diaphragm, is myelohyoid, attached from the line that we have in mandible, myelohyoid line, and at the midline they reach to each other. Again, we will see in the next slide. But in this, by all of the muscles inside covered by the mucosa, as you can see here. All this part covered by mucosa. And tongue and genioglus, these three made the floor of our oral cavity. There are two spaces inside of the oral cavity, vestibule and main cavity, main oral cavity. Here, this is the main oral cavity, and vestibule should be
between the teeth and the lip.
Excellent. Between the teeth and here, you can see. And these two spaces, vestibule and main oral cavity reach to each other in which point? At the posterior of the third molar. If you push your teeth to each other, from that part you can have access to the main oral cavity. What's the useful of this knowledge? Someone, it may be because of some problem, being locked, they must. So you can go and open this from the behind of the third molar. Or it may be you want to use some instrument to help him being breathing. So you can use this part. Also, this jaw being locked, but we can have access to the main cavity. It's clear?
Yes.
So, If we look at the tongue from the inferior surface, as you can see here, there are some arteries there, lingual artery you can see here, and dorsal lingual vein and lingual nerve you can see here. Immediately, they covered by the mucosa that cover the inferior surface of the tongue. And here you can see frenulum. What's the frenulum? Here again we have frenulum. Here we have frenulum. Frenulum is a part of mucosa that fix the tongue or the lips. Here you can see this fix the most, I mean the posterior part of the lower lip, and here another frenulum we have for the upper lip, and this one
The tongue.
especially is for the tongue, so not letting it be have more freedom. So they act as a sling, as something that limiting the movement. Okay, again here, I'm sure it may be clear. We have three main salivatory glands. Here we have parotid, and here we have submandibular, and here, as you can see, we have sublingual. Sublingual and submandibular ducts open into main oral cavity. As you can see here, below the tongue, on each side, I mean left and right side, you can see main duct of the submandibular exactly lateral than the frenulum. Look to the frenulum. This is the frenulum here at the midline. This is the frenulum. Exactly at the side of the frenulum, we can find the ducts of the submandibular. It goes through the submandibular gland to under of the mucosa and finally reach here. And there are a lot of ducts for sublingual gland. So because of this, when we go to dentistry, they put some pad in inferior than or tongue. Yes? Because it was absorbing the secretion of this mucosal part of this gland. So, the duct of the submandibular and sublingual open in rear oral cavity. But in this picture, as you can distinguish, the duct of the duct of the parotid gland open at the vestibule at the level of which it is second upper molar teeth on the right and left side. We have the duct of the parotid gland. Again, because of this, they put some pad under our chin at this level. When we remove the mucosa of the upper part of our oral cavity, you can see palatine nerve and palatine arteries that are going to supply all parts of the upper jaw. I mean the tooth and the connective tissue that make this part, and they are some branches, they have some branches that reach to the soft palate, and some fat that make this part, and some taste bud that we have here. So they have to be supplied by these nerves and arteries. And here, when we remove the mucosa, you can see the muscles that make this soft palate. Which muscles do we have here? Palatoglossal, palatopharyngeal. This is the palatopharyngeal. Look here. This one is palatogloss, because from the palatine reach to the tongue, and posterior than this we have palatopharyngeal. between palatogluteal and palatopharyngeal, what do we have here?
Tonsil.
Tonsil. Excellent. And especially uvula has muscles. So uvularis, this muscle belongs to uvularis. And two other muscles, what do we have? For the soft palate, tensor veli palatine and levator palatine. Levator palatine means pull up the palatine, pull up the soft palate, and tensor veli palatine means it's trying to be what? Pull the palatine and cause it being, flat. So all of this muscle innervated by which nerve? Great. Which nerve supply or muscles from the soft palate?
Lingual for the tongue.
Vagus nerve. The vagus nerve. 10. The 10th the mental nerve, cervical nerves supply this, but there is an except that it's back to the tensor veli palatine. Tensor veli palatine will be innervated by trigeminal V3 mandibular branch of the trigeminal. So all the muscles of this part supplied by vagus nerve except the tensor veli palatine. Tensor veli palatine will be innervated by trigeminal. Yes. And about the tongue, we should be aware it can be divided into anterior 2/3 and posterior 1/3. As you can see here, it belongs to the pharynx, so we say pharyngeal part of the tongue and filled by the tonsil. These are tonsil that we have here, and the anterior part covered by taste bud. And I'm sure you learned this from the histology. And again, you can see the marginal cut of the palatogluteus and palatopharyngeal here. And this, what is this here? Epiglottis belong to the larynx. So exactly below the tongue we have the larynx. So because of this, you can see the epiglottis that when we are swallowing something, it closes the trachea and let the swallowed material goes to the cell. Yes. Tongue made by intrinsic and extrinsic muscles. How many? What's the meaning of extrinsic muscles? The muscles that originate from somewhere else instead of the tongue. But intrinsic means muscles that originated exactly inside of the tongue. So here you can see the muscles that we say
Extrinsic.
Extrinsic. Same as this one. Look to this from hyoid to the tongue. Hyoglus, genioglus, and this one is styloglus. And one more, palatogluteus. Excellent. This one is palatogluteus. And all of these muscles innervated by hypogluteal. No, facial for the taste bud. Hypogluteal nerve. In it, just exception back to the palatogluteus, because palatogluteus is one of the muscle for soft palate that I mentioned you before. Okay, still this palatogluteus take part. We say it muscle for the soft palate, and here for the tongue. We say it's belong to the tongue. I told you all the muscle of the tongue innervated by hypoglossal nerve, okay? Except palatogloss. As you can see here, palatogloss, because it's one muscle of the soft palate, and all the muscle of the soft palate innervated by vagus nerve, except the tensor very palate. So again, we review. This one is hyoglus, genioglus, styloglus, and palatogloss. Can you tell me about the genioglus? What, with this picture, what will be the action of the genioglus?
The tongue, getting the tongue outside the mouth.
What happened when it's contracted?
Hold the tongue outside, to the outside. Right?
Yes, let the tongue come to outside, because as you can see here, it originates from this part and attached to the tongue. Yes. So when this muscle being paralyzed, it means the tongue has
outside.
this. Yes,
Getting into
that
the
goes back and
Chop.
cause, yes, gotcha. Okay. And what about the palatogloss? What will be the action of the palatogloss? It's help to be pulled up and backward the tongue. And the same as styloglus, as you can see here. Styloglus pull up and laterally, that one pull up and in medial direction. And intrinsic muscles of the tongue can be like this: transverse muscle, vertical muscles, and superior and inferior longitudinal muscles. What do you think about the action of these muscles? I mean the intrinsic muscle. The superior and inferior longitudinal muscle, it being contracted, what happened?
Widen and shorten the muscles.
It's helped that the tongue being shorter, because superior and inferior longitudinal. Yes. What about the transverse? These are the transverse.
Widen the muscle.
Yes.
Tongue.
When they being contracted, help that tongue being wider, or being, I mean being a bit, what we say?
Widen.
Thinner.
Not wider,
Thinner.
teeny.
Thinner.
And what about the vertical muscles?
Get it long.
What's the?
Get it like this.
Look to the direction of these muscles from the superior to inferior. When they being contract, they cause the tongue being thin. Okay? And it may be being longer. Here you can see the submandibular gland that is divided into two parts, deep and superficial part. We can palpate superficial part here, and deep is covered by myelohyoid. This is the myelohyoid muscle. Myelohyoid. So the posterior edge of the myelohyoid that make the floor of our mouth, it's divide this gland into two parts, deep and superficial part. And you can see here, deep and superficial part. Again, you can see that this green one is the duct of this gland that is going reach to the frenulum of the tongue. Lingual and hypoglossal nerve. Hypoglossal nerve innervate all the muscles, and lingual make the sense of the tongue. General innervation or sensation of the anterior two-thirds of the tongue back to the lingual, and the posterior part of the tongue, the 1/3 of the tongue, I mean pharyngeal part of the tongue supplied by nerve number 9. Number 9. Do you get this? Do you know the tense nerve? We say vagus. And 11 should be 11 should be accessory, and 9 should be glossopharyngeal. Okay, this one supply the posterior 1/3 of the tongue. So the anterior 2/3 of the tongue being supplied by the lingual, of course the sensory and the salivatory back to the facial, the parasympathetic branches that comes through the facial and reach to the tongue by the lingual nerve. And hypoglossal, as I mentioned, supply the muscle. And this green one is the duct of the submandibular. On the way that you can see here, the duct cross the lingual nerve. Is clear here. Look to this lingual nerve and the duct of the submandibular, it's cross the lingual nerve. We will, if we have another class in the practical, we will find this in the oral cavity at the sublingual part of the glutamate. Okay, so this one is lingual artery that is going to supply, make branch to the tongue and the floor of the mouth, and hypoglossal nerve, and this one. These two, hypoglossal and lingual nerve, is over the genioglossus muscle, but the lingual artery covered by genioglossus muscle. It's clear? Yes? Okay. Here it shows you the roof of the tongue, the mouth that made by the maxillary and palatine bone. And here this one is sphenoid, as I mentioned you before, sphenoid and hyoid and mandible was the single bone that take part here. And of course, temporal bones take part to make the body part of the oral cavity. And here again you can see all this part that covered by the mucosa, and of course the sinus that we have here. I'm sure you know that we have different kind of bones, especially one of them that we have around the nose and ear. They are with what kind of bones do we have in a skull that being special? Pneumatic bones. They have some space, empty space that covered by the mucosa. Sphenoid. Here you can see the empty space of the body of sphenoid that filled by mucosa, and especially for the maxilla and frontal. Yes, sinusitis is the back to inflammation of the mucus of this part that being surrounded around the nasal cavity or bones that make our face and head. And here again we can see the soft palate, this part, and the adenoid that I mentioned you is this part. At the most upper part of the pharyngeal part that you can see here, we say nasopharynx. Yes, this one is nasopharynx. So the upper part, the roof covered by this tonsil that we say adenoid or third tonsil. Parotid gland being like a cone, the base is near the zygoma bone, and the neck reach to the cervix, as you can see here, and this one is anterior border of this gland that the facial nerve when reach to the our face here on the right and left side, it divided interior of this gland, and then you can see here all the branches separate from this gland. So the surgery in this gland will be very important because of the branches of the facial nerve, and all the branches of the facial nerve innervate the muscles that we have on our face. We say mimetic muscles. They are very teeny muscles that attach in some part to the skin and show your friends or the people your emotional interest. When you are be happy, it will be shown by changing your face, or angry, because of the function of these muscles. So because of this, they say mimetic muscles. We have a lot of muscle in head and neck. They will be introduced to you, and you can see some of them here. We have some around our eyes, or around our lips we have, and here we have some that taking part to function of the mandible. Here it shows you that the parotid gland is located between the mandible anteriorly and the temporal bone posteriorly, and the course of the facial nerve is clear inside of this gland, and from the anterior border it be diverse and reach to the to our muscles that they should be supplied. Here is the name of this that is not belong to this section, so we cross. And here again we can see the superficial part of the submandibular gland that I mentioned you here below the mandible. We can touch under the although we have the skin, we can touch this part, but the ducts is being the course of the duct, as I show you, being inside of the oral cavity. Now, in this slide, it shows all of these together. I mean, parotid, submandibular, myelohyoid, that dividing the submandibular into two parts, deep and superficial part, and again, sublingual, that all the ducts open under the tongue. And this green one is the duct of the submandible. Thank you so much for your attention. And I correct all of your quiz. I will give you now, but I think we need more practical class. I will discuss with the who is responsible. If there will be any possibility, I hope we can have more extra practical class.